Okay, so good afternoon, everyone. This is Aliyah from the Asia eHealth Information Network. Welcome to our 18 Hour, our bi-monthly webinar series where we feature topics on eHealth, health information systems, and information technology for civil registration and vital statistics. This webinar is attended by 25 countries in South and Southeast Asia, mostly members of the AHIN. If you're not yet a member of the network, it's okay, and we'd love that you join us twice a month here in this webinar to also learn from topics that are useful in your network as an eHealth professional. We also invite you to join AHIN for free and see for yourself amazing collaborations that we can do together in the future. AHIN Secretariat is at the National Telehealth Center in the University of the Philippines and is supported by the World Health Organization and partners. Our topic for today is how to achieve national eHealth goals through partnerships with the Director of HealthEnabled, Dr. Peter Benjamin. Partnerships Partnerships have the power to create opportunities to improve eHealth capacities nationally more than evidence-based research and compelling statistics alone. Today, this webinar will help you understand how to achieve national eHealth, including mHealth goals, through effective partnerships, alliance building, raising the bar of eHealth projects. And some things to remember before we start our session: the platform, how to participate, the program, and the email feedback. We're now using Cisco WebEx Meeting Center, and if you are encountering problems to participating in this meeting room, just like what happened earlier, please log out the session and rejoin immediately in our WebEx website. That is bit.ly.com/ahinhour. Our room number is 867-133-748, and our password is Africa123. Your mic will be mute during the meeting, and if you want to actively participate, you can happily send your feedback to the session, chat your response, and post your questions. You can send your feedback by clicking the feedback button on the right side of your screen below the participants window. It's the dialog balloon with a check mark. On the drop-down menu, you can respond by a yes or no, say the presentation is too fast or too slow. You can also appreciate the speaker by a virtual laughter or an applause. Let's try to get a feedback in this room. Can you answer my questions? My question, are you feeling well today? You can send your check mark or your X mark to me if you feel well today. Thank you very much for those who have signified their feedback. Gilbert Nina, Henry Joshua Igna, Anika Mendoza, Radityo PUW, and for the rest, if you can hear my voice well, I hope that everything is fine on your side. You can chat your response by typing your message to the panelist, that is either the host and or the presenter. But please remember, you can only chat to either the host and or the panelist or presenter and not to all meeting participants. And reminder, do not post your questions in the chat box because we will have a special option for that. For your questions, click the Q&A tab and then type your question, and we will address this later. Lastly, check your email so that you can read the email feedback that we will be sending to you. And we hope that you could express your thoughts and other evaluations on how we can improve this AHIN hour. Now we're done on how to participate. Let's go to the program details. This program will run for 45 minutes to 1 hour, and you are very free to send your questions to our Q&A box as it arises from your head. So those are the 4 things to remember: our platform, our ways to participate, program details, and the email feedback. For our speaker for this afternoon, I'd like to introduce to you Dr. Peter Benjamin. Peter Benjamin is the Director of HealthEnabled, formerly the mHealth Expert Learning Program, or mHealth. Until April 2013, he was the Managing Director of Cell Life, a leader in mHealth based in South Africa. He has 20 years of experience in the use of information and communication technology for social change and development. He has worked for PopTel in the UK, the SA National Civic Organisation, the Universal Service Agency SA, the Association of Progressive Communications, and was the founder in 1997 of the Link Center for Research and Education into ICT Policy at Wits University, Johannesburg. Originally from the UK, he moved to South Africa in 1994. He has a first degree in physics, a master's in information technology, and his PhD examined universal access to ICTs in SA through the Telecenter program in the late 1990s. He's studying for a master's in public health. Please welcome Dr. Peter Benjamin, our speaker for this afternoon, for our topic on how to achieve national eHealth goals through partnerships. Dr. Peter, are you okay to start the session? I am now transferring the presenter controls to you so that you could take the session away. Hello?
Thank you so much, Aliyah. Can I check you can hear me and see my screen currently?
At the moment, we can't see your screen yet. I think you have to go to Quick Start and then click Share Your Desktop screen or Share My Screen. It's in the middle of the three bottom.
I see that.
All right, your screen is arriving, and there you go. Take away.
Thank you so much. Thank you. Lovely. And thank you very much to all at AHIN, and Aliyah, thank you for setting up all the arrangements here. I'm delighted to speak to the community, the family that is AHIN, and what I wanted to cover is what we are now doing with this organization that we're calling HealthEnabled. But before I start, I am coming with an attitude of great humility. I think you in Asia through AHIN are leading globally in a lot of what I'm going to be talking about. And I know that I have just as much to learn from you as possibly I have to share with you. And I've very much enjoyed in the past conversations with Alvin, Mark, Dr. Bunchai, and others at AHIN. And my main question throughout this hour is how best can we collaborate together, because I see us as partner, as sister organizations, and I'd very much like to learn from and see how we can collaborate in future. HealthEnabled is quite a new organization. We've just been using this name for about the last 3 months. And what we are aiming to do is to support eHealth and mHealth at national scale in many different countries in Africa, Latin America, and with yourselves, possibly in Asia as well. We came out of the organization called mHealth, as Aliyah started saying, the mHealth Expert Learning Program, which was the capacity building unit of the mHealth Alliance. Our job was to support any health organization globally that wanted to use mHealth in their work. And we have supported dozens of organizations that wanted to use this technology. In rethinking our strategy and seeing how could we be most effective in the work that we want to do during last year, we realized that there are many thousands of mHealth and even more eHealth projects in the world. On one listing, there's over 2,500, but most of them are actually quite small. Many of them have indeterminate impact, that they aren't actually proving or coming up with evidence, and very few of them have any form of long-term sustainability. So rather than just adding to another few hundred, perhaps another 1,000 of these small little pilots, what we came to realize quite clearly is if we actually want to improve eHealth and mHealth and all the other words, telemedicine, ICT for health, health informatics, all the other terms that we use around the use of electronic technologies in health, digital health as I'm going to call it, then we had to approach it differently, not more small little projects, instead working in many ways as eHealth has been doing for the last 5 years to try and get coherent, national level, large-scale integrated programs. And from the work that we were doing in Nigeria, as one example, we came up with that there are 3 main areas that we need to get right in this. In many ways, this actually allied to the quite famous now eHealth, if you like, steps to national capacity building and scale that I've got up on my desk, certainly learning a lot from you. But from the Nigeria experience, there's at least 3 areas that need to be working to be able to get to a coherent national system. The first is the national policy. This is talking about the paper, the official policies from National Department of Health, perhaps from other people, the Department of Telecommunications or ICT, the regulator of telecommunications, the ICT procurement agency for government, a few other official governmental bodies. And for example, in Nigeria, while there was a lot of work in this area, there was no overarching eHealth policy, and there were many different related policies that didn't coordinate, and in some cases actually conflicted with each other. No one talking about ongoing capacity building, and so while there was a lot of work, it was almost like different cogs not meshing with each other, almost coming into conflict with each other. If you get national policy right, you still haven't actually done anything that affects anyone on the ground. You produce the papers, the policy, the alignment, the agreements from government, but you still haven't done anything. The second area moves towards actually doing things, implementing projects, and that's what we're calling sustainable programs. This is the level, again, that eHealth is very familiar with, that's talking around building the high-level partnerships, linking with various different organizations in the ecosystem, the value chain, from the health workers to the supplier organizations to the health implementers to the capacity building groups to a range of others. Definitely in here is talking about long-term sustainability, writing in how to link this to large-scale health systems for whether your sustainability is going to be ongoing public funding, whether your funding is going to be through some form of user pay or insurance or advertising model. The wrong answer is donor funding for long-term, but that's thinking through all those sorts of things. Definitely at this level, it's about overcoming the siloed individual fragmentation. This is about open systems, interaction, linked APIs, data dictionaries, all things like that. And if you get this level right, you can have lots of activity happening on the ground, people interacting with it, but you still don't know if you've got any health impact at all, if it actually impacts on the life or the health, the mortality or morbidity of any individual. That's where the third area comes in, effective use. This is much more thinking around how these systems interact with individuals to lead to some sort of change, whether it's directly working with individual patients or the behavior change, messaging to come back to the clinics, the supporting health-seeking behavior, adherence, things like that. Whether it's tools for health workers, frontline health workers, or facility health workers, whether it's the back-end systems, whether it's the patient record systems, supply chain management systems, training for health workers, all those different things. And the main issues there are user-centered design, iteration, making sure that the people who use the system help design the system, making the systems easy to use, locally relevant, feedback in all the data systems, all things like that. So while there's a lot of people doing effective use, and that's the literally thousands of pilots, And there's some people doing sustainable programs like Mama in Bangladesh and now India, like PATH in various different countries like Johns Hopkins University, like places like that. And there are few people working on national policy. Absolutely, eHealth is in there. And actually eHealth in some ways is, of course, working on all three areas. There are very few examples we can see where all of those three work coherently together to make an integrated digital health that is supported nationally, national policy, that has long-term scale, sustainable systems, that sustainable programs, and thirdly, has impact on people's health and the work that they do through effective use. So what we are trying to do is work in a small number of countries, probably of the order of 5 or 6 countries in Africa, Asia, and Latin America over the next few years to try and align all of these things together. So, very simple schematic of it. What we're hoping that HealthEnabled can do, together with partners like yourselves in eHealth and the individuals in this network, is work with national policy in the countries to produce informed decision-making, support and capacity build the sustainable programs so we can design for scale, operationalize and build the relevant platforms, and then the ultimate aim of all of this, get large-scale effective use, evidence-based user-centered design for public goods and tools that can be shared. And we hope, our hypothesis is that if this works, we can lead towards large-scale, impactful, sustainable national digital health systems. So very simply, you can read this as well as I can, but just our objective, our vision is national integrated digital health systems in low and middle income countries that improve the health and well-being for all people by 2020. And you can see our mission around improving health outcomes by aligning national policy, sustainable programs, and user needs to activate the effective and widespread use of integrated digital health tools in low and middle income countries. Again, I think everyone on this call is already doing this. I don't think this is particularly new. I'm just saying that this is the approach that we are taking, and we'd be delighted to be working with you in eHealth and elsewhere. This rather busy slide is starting to talk about what we actually expect to do in the different countries that we are working in. And just to say, most of our work to date has been in Africa. We're definitely doing this in South Africa. Very close partners of ours are doing this in Nigeria. We expect to be starting in Tanzania. We're actually following up contacts with people in Brazil, in Latin America, and would be very glad at the end of this conversation to see if there's countries or organizations in Asia that we can collaborate with in this way. So first, our approach on the left-hand column. In the countries we work, there's sort of fairly standard methodologies that obviously will be adapted in each country that we work with and working with and through local partners. Around the country and institutional assessments, prioritization, mapping and budgeting what needs to be done, linking up with the best skilled people in the expert network that we can, and I'll mention that in a moment, the capacity building and operationalizing, then monitoring, evaluation, and building the local network. And we hope to do this in 4 key roles. There's 4 set of activities we expect to be doing in the countries that we're working in. First is increasing the capacity building for national policy and planning. And that's working directly with the ministries, the regulator, the other relevant bodies, as we're doing in Nigeria and South Africa currently, around supporting the development of the policy frameworks, pulling in the best experts globally and building capacity of local experts as we can, using them, and linking with the global best practice, World Bank, WHO, leading universities and the like. I'll go through the other 4 in the next few slides. So on the first of these roles, an example is what we're doing in South Africa. We're working very closely with what's called the Mum Connect program, which is like the Mama messaging, the Mobile Alliance for Maternal Action, that has been taken up now by the national government to send messages out to up to 1 million pregnant women, mothers of young children, while having a tool for data collection and supporting frontline health workers, while building the National Pregnancy Registry. And our organisation HealthEnabled is on the national task team and doing various areas here around building the policy framework, implementing and the design, supporting the monitoring and evaluation, and linking with global expertise and efforts around this. For example, in Asia, the Ananya program from Bihar, now widespread through India, is absolutely a leader here, and we're linking up South Africa's Mum Connect program with Ananya because we have a lot to learn from what you're doing there. The second of the roles we're going to be doing is building the capacity of implementers, of the practitioners. And this is on this slide, you see the range of organizations, both large-scale health organizations like UNICEF, Red Cross, and Médecins Sans Frontières and others, and some of the donors that we are talking to about linking here. But currently we're working directly with an HIV organization in Tanzania called the Elizabeth Glaser Pediatric AIDS Foundation. We supported them in developing a tool for community health workers in their facilities, and we're now doing other capacity building with them. And with another organization called Mothers to Mothers that supports HIV positive women in about a dozen African countries, we're designing their E and mHealth strategy for them, while building local capacity, designing job descriptions, hiring the right people, just building the organization so that they can make use of these technologies. The third area we'll be working with is around what we call raising the bar on performance by promoting the standards and transparency. Again, we can learn a lot from what you're doing in AHIN, but this is talking around national scorecards and index assessments of what best practices and how far different countries are in the range of areas: infrastructure, policy, individual resources, enabling environment, sustainable business models, all those things, both for at country level and also for organizations. So where organizations want to learn almost the steps they need to go through, we'll have models and able to support. And also be producing some prizes. By the end of this year, we're going to be awarding some prizes in the countries we're working with that will be, we believe, announced at the mHealth Summit and other events later this year. And the fourth area we're going to be working with is around building networks, both at country level, regional level, and global. And at the regional network, that's absolutely AHIN, obviously, is the organization in Asia that we'd most like to partner and collaborate with. But in other parts of the world that aren't so fortunate to have people like Alvin, Mark, and Dr. Buncha and the rest of you, haven't got those networks. We're directly working to build that in Africa, partnering with some groups that I know Alvin and others have been working very closely with, the African Network for Digital Health, ANDH, the 6 leaders, where we'll be part of the founding meeting there next month. And we're building what we call Health eAfrica, which is a much wider network of anyone involved in eHealth that wants to know what's happening, be plugged into opportunities, in many ways building the market, letting the people who need capacity and resources link to the experts. And we do very, very strongly trying to build local expertise. There have been too many times where people fly out from Europe or North America to come to a country for a week and write their national policy. That's exactly what we're trying to get away from. In the last year, I've had conversations with people in 3 different national departments of health in Africa, and all of them said, almost exactly the same sentence to me. They said, we know there's something important happening with eHealth and mHealth. We know we don't know how to do it ourselves, but the only people we can speak to all look like salesmen. They're all trying to sell me something. They're all trying to say, the answer to your problem is our system, sign this contract and we'll change your country. And there's very little access to experienced, respected, but neutral advice. And that's something we're hoping to assist and work with. So we're developing country networks. We've got a list and community going in South Africa, where we're based here in Cape Town. We've started one in Kenya, in East Africa. We've just started one in Francophone, French-speaking West Africa, with some partners in Mali and Cote d'Ivoire and elsewhere. And so in all the countries we'll be working, a very strong emphasis on building local networks, local skills, training courses, it's like creating, linking the need with the local demand for countries of Africa, Asia and Latin America to solve their own problems. I've referred a few times to what we call the expert network. And in many ways, that's the engine, that's the core of what we are doing. Over the last about 18 months, we've developed a network of, actually the numbers are slightly bigger than this now, of about 70 people who are all global experts in the areas that they are working in. And those people come from 24 countries, speaking 23 different languages, 44 different specialities throughout eHealth and mHealth. And in particular, we're linking with some of the larger health implementing and eHealth and organizations. I'm talking about, as you see at the bottom of that slide, D2 International, Damagi, ICD, GEMB, Johns Hopkins, mHealth Kenya, Empowering Frontline Health Workers, Quaker, Texas James, ThoughtWorks, UNICEF. And while we have a few partners and experts based in Asia, we very, very strongly want to grow that. So to everyone who's listening to this on the webinar, the AHIN Hour, please take this as an invitation. If you would like to join our expert network, we'd be delighted to have you. We go through a little vetting process to check people really do have the skills and experience. We check your CV and if you have any writings and follow up a few references. So that you can respond to any questions that come up. We field questions from people around the world around eHealth and mHealth that we link for free to our experts. We pay the experts a few $100s usually, but it's free to the person who asks the questions, because we're still trying to support the wider eHealth, mHealth community globally. And also, where there are people in as many different countries in Africa, Asia, and Latin America as we can find, we're trying to find local expertise, so that if someone asks us a question from Nepal, or from Equatorial Guinea, or from Venezuela, we can link them to experienced, good quality people in the local country who understand the language, the local context, who will still be there in a year's time to support the ongoing sustainable programs we're all aiming for. So, coming close to the end of my presentation now, this was a slide actually that came from a paper written by Alan Lebreek of Johns Hopkins University and Garrett Mell of the World Health University, talking about how mHealth but also eHealth strategies can link in throughout the value chain of health around universal health access. From the bottom, just accountability, being able to offer services to as wide a population as possible, up through supply, getting good quality health services out there, to demand, linking to the population to encourage health-seeking behavior, to the quality and checking that there's good quality, high-level health services that are delivered that have a health impact, to the cost, the ongoing financial models to make sure that no one is prevented from access to healthcare through lack of financial resources. So we see ourselves as fundamentally trying to support the drive towards universal health coverage, healthcare access to the population of the world over the next 5 years. We've actually set ourselves the next 5 years as an organization to try and do something. We expect actually to dissolve as an organization in 2020, by when we hope our services, what we're trying to do, will be redundant. People will already be doing these things. In many ways, we actually don't even want to talk about mHealth or eHealth. What our job is to make electronic digital health the new normal. If you are trying to do large-scale public or even private health in countries in Asia, Africa, and Latin America, you have to do it electronically. It's not a question. So it's not that we want to create a few more mHealth or eHealth or database or telemedicine or ICT for health or health informatics projects. There are enough of them. What we want to do is to persuade everyone through the value chain, from the health minister to the community health worker on the ground to the patient who's got a health problem of malaria or diarrhea or whatever it is, that this is the way you do health. This is what health means in the 21st century. So I'm trying to move away from just speaking to mHealth and eHealth conferences. We're about health systems. We're about universal health coverage. We're about how to improve the lifespan and the health of the majority of the people on our planet over the next few decades. So, as we're saying, whereas currently there's very little overlap in most countries in the global south around national policy, sustainable programs, and effective use. And I pay credit to eHealth for being the leaders in thinking through particularly the link between national policy and sustainable programs. Over the work that we're trying to do in the key interventions in a few countries, we hope to increase the overlap between it so that by the time that we dissolve, that we disappear around 2020, everyone involved in the different areas of digital health has an understanding of the other areas. There's a much bigger overlap. People who are trying to develop a new little software app understand the national regulation to do it, understand how to make the global and high-level partnerships and to get sustainable long-term business cases. People who are writing policy can think through how this will actually impact individual users, the privacy issues, whether people will trust these systems or not. So moving to coherent integrated digital health systems where there's overlap in the three areas we've been talking about. And my final slide here is, I won't talk to this too much, but this is what we're hoping to do. This is our, if you like, our theory of change. The activities at the bottom of brokering, advising, convening, leading to those four strategic roles I talked about around policy, around capacity of delivery organizations, raising the bar and building the networks, so that in the next year, we've got funding now to work in 2 countries at a serious level, definitely South Africa, probably Tanzania as well. And then over the next 5 years, we want to be working in 5 countries. We expect Nigeria, we expect Brazil, and we are opening the conversation to see if it's appropriate to do that in which Asian countries represented by eHealth. That's something I very much would like to get out of this. So that in the long term, what we want to be measured on is actually health outcomes. We want to be able to show that these integrated digital health systems over a number of years, like 3, 4, 5 years, can increase the coverage of quality healthcare, can increase the number of people receiving treatment, can reduce levels of mortality in women, children, the other areas we're talking about. That's what we want to be measured on over the next 5 years, not just how many pilot projects were started. And we're working with people at Johns Hopkins and the World Health University on exactly how to measure that. I don't know if you know about what's called the Live Saved tool, LIFT, which is a way of modeling the health economic impact, actually measuring it in lives around different of these health interventions. And then with our mission and vision, as you see there. So with that, I'd like to wrap up my monologue here. Thank you very much to Aliyah and the rest of you for allowing me to present around this. But I very much just want to stress we're a new organization. We have some ideas and some bigger hopes and visions out there, but we're very much looking A, for guidance, and B, for partnership. And we know the best people to be talking with in Asia and globally are yourselves. Another thing I'd just like to stress that we very much are talking through the work we're doing around those 9 green tree principles of ICTs for development for health that have come up. If you don't know about them, can someone please mention that? And I'm very happy to go through them that we use in our work. One of my other slides often talks about that. We're doing work in about half a dozen countries currently actively, and we'll be doing large-scale work, particularly around elimination of mother-to-child transmission of HIV in South Africa, and we expect Tanzania over the next year or two. And from some of the conversations I've had, particularly with Alvin, there are about 3 or 4 areas I could see that we could collaborate between ourselves as HealthEnabled and yourselves as AHIN. But I think I'll finish now, and hopefully those will come up in the conversation. So thank you very much for the opportunity for the last half hour or so of talking. Very open to questions, comments, other discussions, and over to you, Aliyah, if you'd like to lead the discussion.
All right, thank you very much. It's a very wonderful presentation, and we've learned a lot about what HealthEnabled is doing and how, and we also find some synergies on what AHIN is doing currently. I have 2 questions on the floor, and may I just read it, and I hope you could address it on behalf of HealthEnabled. This question is from let me check, from Dr. Manjula from the Ministry of Health in Sri Lanka. How is the acceptance and collaboration with the governments you work with, and what strategies did you use to win those governments?
Thank you very much for the question, Dr. Manjula. As your question suggests, it is often a long and quite detailed process to establish coherent communications, let alone win trust of these with different governments. There's only 2, I'd say, that we so far have been fully successful with. One is South Africa, where I happen to be based, and very luckily I've been involved in this work, as Aliyah mentioned very briefly, for about the last 8 years in South Africa. I was the head of a not-for-profit mHealth organization called Cell Life, and through that I got to know the health minister and some of the senior officials. And it literally took about 5 years from my first meetings to formally be involved in the planning and the task teams, and be directly involved in helping write policy and the rest. So it definitely is a very long process. If I may, I initially was talking about mHealth. The first question I had from a senior Department of Health in South Africa official was, mHealth, Peter, are you talking about maternal health or mental health? And luckily things have moved on a little bit since then. In Nigeria, it came through a process, again, that took about 2.5 years, actually led by the mHealth Alliance, which I was formally working with, that this project came out of, where there was some funding from NORAD, the Norwegian governmental donor, to support what is now known as the Saving 1 Million Lives program, which is a large-scale maternal health program in Nigeria, where there's a very coherent ICT policy that the mHealth Alliance and now there's a local organization in Nigeria are leading, and they've seconded someone into the National Department of Health, and they chair the I think it's 2 monthly meetings of departments of health at the federal and the state level, and the regulator, and 3 different government departments, and the rest. So the short answer is, as clearly you know from your own experience, it takes a very long time, and it's not a one-off thing. It's not like you have one meeting with the minister or the senior officials, the permanent secretary or the director general, and you get a signed letter and then everything happens. You have to win trust at every level that you're working with. I don't claim that our organization works miracles. We can't come into a fresh country and say we'll convince everyone overnight. That's just unrealistic and actually very arrogant to even assume it. However, there's a much more fortunate situation that over the last few years, there are many governments that we're starting to be in conversation with who very much want this sort of support. Governments who have been coming to some of the global ICT conferences, who've been asking the World Health Organization for advice, who've been trying to get the London School of Hygiene and Tropical Medicine, or Johns Hopkins, or Harvard, or one of the Chinese universities, or others of the global universities to assist them. And so probably the easiest way for us, we only want to work in countries that want to work with us. So that's, if you like, that's giving us the easiest way in. We want to work with countries where there clearly is a serious health issue, that there are improvements to the health system, to the health delivery that can lead to impacts on maternity and morbidity. And we want to work with any government and any large-scale health implementing organization that would like to work with us. I hope that starts to answer your question, Dr. Mandrila.
All right. Thank you very much for that very comprehensive answer. More questions are piling in our Q&A box. Let's read from, let me get this. Let's read from Ramon Duremdes. Do you have a view about the role of government, specifically departments of health, in developing and deploying electronic medical records, where the private sector and civil society are also providing the standards-compliant EMRs?
Okay. Thank you again very much for the question, Dr. Enders. I think governments have a very important role, but that is not necessarily the role of implementing it themselves. In no country that I know of, and perhaps you can give me good examples that I'm not aware of, but in no country that I know of is the private sector able to coordinate and come to coherence themselves to get properly interoperable, coherent, unique identifier systems that can be used broadly. Of course, there are some standards, and of course, different health systems providers are trying to, if you like, sell their own system. The US is a particularly bad example of private sector-led systems that lead to complete silos and lack of interconnectability of the various systems. In some countries, I know government is working to set the coherent standard, and then just says everyone else has to do it. In many countries, as you know, government is not actually able to implement coherent national digital health systems down to the patient record level, and instead we've got aggregate systems like the district health information system that just count numbers of people in various different categories rather than individual patient record systems. But I know of examples in about 6 countries, though one Latin American or the others in Africa, and I'd be delighted if you could tell me more about Asia, where government is playing a very useful role in getting the right players together and then basically arbitrating and say, this is what the national system will be like, and then requiring all the other players to basically follow that model. And as you may well be aware of, there's something called Open Health Information Exchange, OpenHIE, which is it actually came out of a project in Rwanda that's now being used in many different countries, which is the best model I've seen that allows there to be an open access model that is not proprietary, but anyone can use their own private or public system to link into that in a way that is coherent and allows interconnection between the different areas. But again, I'm talking too much in this hour. I'd be very interested in hearing from yourself, Dr. Rendez, and the other experiences from Asia. Thank you again.
All right, so okay, we'll move further to more questions in our meeting room. This question is from India, I believe. Let me just read that. In India, okay, from Dr. Rajiv Joshi, in India, 80% healthcare is provided by private players, whereas only 20% healthcare services are provided by public health departments. How do you think can help this in such situation? How do you think you can help in such situation?
Thank you again for the question, Dr. Rajiv Joshi. I think my first answer would be we could only assume we could help with great humility. Private, as you rightly say, in India, and actually in many countries, it's actually the majority of countries in the global south, the private health sector is actually much more effective in providing treatment, particularly good high quality treatment in many different countries. And a report I was reading actually last week was saying that actually the majority of countries, even in Africa, Asia and Latin America, care is provided in the private rather than the public sector. Though remembering the private sector isn't always just the for-profit sector. There's a lot of other private trusts or religious organizations or others providing care. So your question is absolutely appropriate. In many of the countries of the global south, you're right, it is the private sector that is more significant deliverer. To respond more generally, I think the approach is much the same. You don't obviously have such centralized control if there isn't one central government agency providing most of the implementation. But the issues that we were talking about of needing to get coherent policy and long-term sustained programs and effective use are actually just as relevant to a private organization as it is publicly. What obviously is different is there are many different decision makers. It's not just trying to convince one bureaucratic hierarchy where you can get a high-level decision, but with a lot of problems and delays and local politics and dynamics should filter down through the whole system. You have of the order of 100 or more large-scale health players, or possibly even thousands in a country like India, that you'd have to speak with. And then it absolutely highlights the need for the networks, the sharing of experience rather than any form of centralized control. But I'd actually say, and again, open for debate, that the principles are actually much the same. You still need to raise the levels of performance. You still need to argue towards interoperability, coherent standards. You still need to link the understanding of policy and what we're all trying to achieve, and sustainable programs and the effective use. So obviously the private organizations will have their own objectives, and absolutely honorably, those need to be included in the framework. For the private sector for-profit companies, they need to be able to make a profit for it. And there's nothing I've said today in any way minimizes the importance of that or cuts across that. Though obviously where there are competing private players, it's that bit harder to get coherent support and collaboration for systems, when often actually the information and the proprietary systems are the added advantage that the companies hope to be able to make profit from. So yes, it definitely is harder, but I think the same approach is appropriate, and and the need to get coherent systems that link between policy, sustainable programs, and effective use that actually change lives is just the same in a country that's private sector health dominated than in public sector health. But again, just to conclude, every country is different. And our approach isn't a cookie cutter one, but the first thing we do is hire local project managers who understand the local country and context, and we hope already the trust and contacts within the wider health sector, public, private, NGO and others. But yes, this is each country is separate, has its own dynamics, particularly a country like India, which, as you know, there's a larger population in India than all of Africa combined. So yes, the way to approach a country like India is with great humility, but still believing that these changes should happen and are possible. Thank you again.
All right. So I think one important thing that we should remember is that even the process is stages. We are going to somewhere, and we are objective-oriented and not just goal-oriented. There's a follow-up reply to the question earlier asked by Ramon Durendes. He said, in the Philippines, the private sector and civil society are in fact implementing DOH and National Health Insurance compliant EMRs. The question is, if the private sector and civil society are able to provide this, should the DOH do too? So should the Department of Health follow through the private sector and civil society-led EMRs?
Okay. Thank you. I've read a little bit about the extremely interesting example in the Philippines, and actually it's an example cited quite often where I am in South Africa, which is also starting to implement a national health insurance system. The very short answer for me is, if it's working, don't try and fix it. And if there are coherent EMR systems that are coming through the private sector and the civil society players, I would be very resistant to government coming in and trying to basically set a system that may not be more widespread appropriate. I had a very quick chat with Alvin when we were in Washington, D.C. About some related things. So I think it is important for the National Department of Health to, if you like, definitively state what the national system is. So basically to end ongoing dispute. But the organization that actually innovates and implements and builds that system could be the public, the private, or the NGO. And in a country like the Philippines, as you're saying, Dr. Enders, it definitely seems that it's the private and the civil society that are leading in this area. And I don't think it makes sense to the Department of Health to try and delete or almost undermine something if it is more large scale and being affected. I notice we're just over the hour. There's a few things I'd like to say in closing, but over to you, Aliyah, on how we manage the time.
Oh yeah, yes, I am about to remind that. And for other questions that were posted in our chat room, we will send it to Dr. Peter Benjamin, and I will ensure you that he will answer this question so that it could be delivered to you at for and will be reported to the email feedback that I will be sending to you. Some last words and wrap up that you would like to do for this session, Dr. Benjamin?
Thank you so much. I'd like to close as I started, showing my great appreciation to the AHIN organisers and yourself, Aaliyah, for giving me this opportunity. There are a number of different ways I would be delighted to follow up the partnership between ourselves in HealthEnabled and AHIN. The first is we'd like to work with any of the governments in Asia at the level that you want, informally exchanging ideas, or possibly even being one of the larger scale countries that we'd be working in. But I would only do that directly in partnership with AHIN. We've got no interest in doing separate things in Asia. We're happy to work with and through AHIN in the area that you are so widespread. The second area is if there's any way that the expertise in our expert network could be of use either to AHIN as an organisation or the individual people on this call, we'd be delighted. Because, as I said at the start, we are set up, we're funded actually, as was mentioned, by Johnson & Johnson. We get some of our funding, we get some of the funding from USAID, we're following up with about 4 other donors and others. But basically, we are funding to respond to questions for free. So if there's any question on wider eHealth, mHealth, ICT for health, telemedicine, health informatics, digital health, whatever you want to call it, that you have that you think we could try and address, please email through to us. I think you have my email address as peter@healthenabled.org. Please do so, and we'd be delighted to link with you. Thirdly, as I think you've picked up, most of our work currently is in Africa, and we, together with other people in the African Network for Digital Health, are very interested in setting up something like AHIN in Africa. And actually, there's going to be a number of conversations in a couple of weeks' time in Ghana, in Accra, in West Africa, exactly on how to do this, working with six people, the original founders of the African Network for Digital Health, ourselves, and about 3 or 4 other organizations on how we can build an Africa-wide network, something like AHIN. So possibly later this year, there will be an African sister network to AHIN, and I look forward to that partnership. And the very last thing I'd like to say is to everyone on this call as an individual, if you would like to join our expert network, we'd be absolutely delighted to have your application. And how that could be useful is, one, the expert network, we share global best practice. It's sort of like a small peer-to-peer expert sharing the knowledge. There's quite a lot of little projects and opportunities for work that come up that we divide up among the expert network, questions or larger consultancies, or even this full-scale jobs working in the core countries. And we'd be delighted to work with you either as individuals in the expert network or as governments or as more widely AHIN. And with that, thank you very much to Aaliyah, Alvin, Mark, Buncha, and the rest in AHIN. I've been delighted to speak with you. Thank you very much. Goodbye.
All right. Again, also many thank you to Peter Benjamin and HealthEnabled for this session. We are so glad that many countries are in this meeting room. We have representatives from the Ministry of Health in the Philippines, Nepal, Maldives, Mongolia, Bangladesh, Sri Lanka, Thailand, India, and for those whom I was not able to mention, please chat me or just feel free to email me. Please stand by also for the email feedback which I will be sending to you. It's just a five questionnaire form, which will answer for us to know your feedback of this session. Thank you for being with us this afternoon. I invite you to our next AHIN Hour on February 27, and our topic is on running a government-wide telemedicine network via the Ontario experience. So if you have further questions, feel free to email us at secretariat@ahin.org, and we will also connect you to Dr. Benjamin for further questions. That's it. So see you next AHIN Hour on February 27. Bye-bye.
Thank you so much. Goodbye.
All right.